It looked like Dr. Goodman's name was on it. I know that the cath lab was crazy busy that day, and so I'm guessing that Dr. Jefferson had asked Dr. Goodman to do the cath, and that's why. But then Jefferson was the one that called me. So, what basically they concluded on the heart catheterization done by Dr. Goodman. And I'll say that both Dr. Goodman and Jefferson are very experienced at putting in stents. So usually when I get a call from one of them about somebody needing bypass surgery, it usually means that they think that the amount of disease in the arteries is too much to do stenting.
Yes.
And it's not a good idea.
Yes.
So I don't know how much of that they told you, but if you go back to my 3 principles, I said that I would only offer things that are designed to improve lifespan or quality of life, right? And so when you look at coronary artery disease, when you have complex coronary artery disease involving either all 3 blood vessels or disease involving the left main coronary artery or the main artery, the LAD, in a long segment that's narrow, we know that the data is that surgery is the best long-term treatment.
Yes.
Okay.
We're very much in favor of getting that done.
Okay. And surgery is taking the highest upfront risk for the longest term benefit. So stenting, you get stenting, you go home the next day.
Yeah.
Surgery is not like that. I will say that when we do surgery nowadays, this is one of the most studied operations in history, that the average time in the hospital for people that don't have major medical illnesses, even if they're 80 years old, is about 4 days. So we do the operation, the patient's usually in the hospital about 4 to 7 days, and the 7 is if they have medication issues or other things that we're adjusting. And then obviously there's a small risk of a major complication like a stroke, death, or bad pneumonia, being on the ventilator longer. We've had kidney failure, people who have some kidney issues to begin with, their kidneys get worse. So we do the testing to figure out what is your surgical risk so we can discuss that with you. So you may have met my assistant already. That's what they're doing. They're collecting the information. When somebody has had recent stenting, an important thing to discuss is what is the risk of stopping the blood thinner that you're on with the pills. That's why you're on this medicine called Cangrelor, because this is designed to prevent a problem with the stent. If you were to have a problem with the stent during the time that we're letting the Brilinta wash out of your system, we would have to do one thing quickly, either restenting or surgery, okay? And that's why you're on this, to have maximal safety during this time of letting the Brilinta wash out. I did ask Dr. Jefferson when he called me yesterday, can you please check a blood test to see how thin the blood is before we start this? Because Brilinta and Cangrelor, they affect the same blood test. And so they told me, or they did it, and then the result was that it was in the, let me see, I'm just double checking to make sure I got this right. Yeah. So at 9:30 last night, the P2Y12 level was 101. That means the Brilinta is in effect, and so we're letting that wash out. Typically, we would wait 5 to 7 days if it was really thin, because that's how long it takes to wash out. Why do we wait this long? Because this operation is one that we usually don't give people blood products. So I've done this operation a lot on people who are Jehovah's Witnesses who will not take any blood. They will die before they will take blood. Okay, so we do it even on people like that who will take 0 blood. So if we do the operation on someone on Brilinta, we are likely to have to give them blood. Not necessarily red blood cells, but we have to give them blood platelets to thicken up the blood, because the Brilinta is working on the platelets. So, and then often we have to give them red blood cells because they've oozed a lot and that sort of thing. So that's why we're letting the Brilinta wash out of your system.
Okay.
Today is Thursday. I am thinking probably by next Wednesday. So it's, because so Friday, Saturday, Sunday, Monday, Tuesday. Sorry, excuse me 1 sec. So we're looking at probably Tuesday, Wednesday.
Please.
Hello. Hey, Rob. Hey, good. How's it going? Okay, so let's see, where were we? We were talking about the Cangrelor.
Yes.
So I think it's going to be probably Tuesday or Wednesday of next week. Tuesday I'm in clinic. So what I would do is probably I can talk to one of my partners to see if we're the requisite number of days, because when we're on Cangrelor, we can't recheck that blood test because the Cangrelor will affect it. That's why I wanted that to kind of figure out roughly. I would say we usually wait at least 5 days from it, and you took a dose yesterday,
yes.
right? So That's why I'm saying calculating out it's going to be Tuesday or Wednesday would be the earliest that we would do it. So so that's what we're kind of thinking for time frame.
Okay.
Looking at the blood vessels, so the right coronary artery was the one that was stented, so I'll just show you that first. So let me orient you to what we're looking at. Before they inject X-ray contrast, this is the tube that they went into your body with, Dr. Goodman went in, and it's black because it's filled with X-ray contrast. And before he injects it, you can see kind of this outline here.
Okay.
Right, that's the stent material in the coronary artery before they inject it. Now they inject the X-ray contrast, and you can see what we're looking at. So, at the time that when Dr. Tiedemann saw you, there wasn't good blood flow down here. Now there's good blood flow coming down into the main right coronary artery, but there's some disease beyond it into the branch point. This is called the posterolateral branch, the posterolateral left ventricular branch. It's not critically tight, but they called it about a 50 to 60% narrowing. What that means is it's a 10-lane highway, goes down to about 4 lanes there, and there's good blood flow beyond it. We generally bypass anything over 50%, and the reason is because it is impeding flow through there. If you look at it like a highway, if you got a 10-lane highway and you take out 6 lanes, if it's not rush hour, it's probably not that big a deal.
Right.
Not rush hour is when you're sitting here in your room talking to people.
Right.
But if we asked you to run up some stairs or you had to run quickly, suddenly that's like rush hour, 4 lanes is not going to cut it, right? So that's why we do bypass on things over 50%. So here we would bypass the artery, and personally I'll tell you, having done this a long time, bypassing a vessel that had a lot of stents in there is just a safety measure. Sometimes I do it even if the lesion is not 60, because we have had cases where somebody has a stent go down later, and then that's a problem, even around the time after you do heart surgery and things and you manipulate the heart. So bypassing this is good because it'll be protective of that, and it'll treat this anyway.
Okay.
All right, so you have one bypass on the right coronary artery. Then looking at the left coronary system, the left system has a left main coronary artery that splits into 2 branches. One is called the circumflex and the other is called the LAD. The circumflex has a branch here that you can see. That's a tight blockage at the origin of what we call the obtuse marginal. And I'll pull up the report here just to look at what he called each of these things in terms of the tightness. And let's see here. So the circumflex, they called about a 70% blockage at the origin of the first obtuse marginal. So we would bypass that. And then looking at the main circumflex, let's see, what did they say? Yeah, the main circumflex to me actually looks pretty good. There's some disease here right at the origin of that, but looking at the main circumflex, that actually looks pretty good. So I think really the target would be this branch right there. Sometimes what I'll do is I see like there's some disease right at that origin. I'll kind of look at that origin and see if it's worth putting a bypass here. If we bypass something that does not have at least a 50% blockage, it would be like building a detour when there's no car wreck. No cars will take the detour. And if you do that here, the blood will not go down that bypass. It'll go down the main artery and it'll just clot off. So unless it's super calcified, I would just plan on doing the bypass on that circumflex artery. The main artery is the one where if you don't have disease here, we are typically not recommending surgery, because this is the one where bypassing it actually improves survival. And this, you've got kind of multiple areas, but the tightest, he said, is a 95% lesion in the mid to distal LAD. So that looks like it's here. We'll see it in other views, because in that view, you might not be inclined to even call it that tight. Yeah, here it looks tighter. So this is what he's calling about a 95% blockage in the mid to distal LAD. And the other portions of this are not critically tight. Maximally, he calls them 50% in everything from here down, because what he's using is, he's using the size of it here and then comparing the smaller areas here. This is probably the tightest area, but again, you see good blood flow going through that. But we would plug in our bypass out here beyond the blockages to get good blood flow beyond that blockage. So, and then the diagonal branch, which is one of the branches off of the LAD, also has some disease, and I think, let's see if that previous one kind of shows that. Let me see, maybe this. Yeah. This is the diagonal branch, and in your case it's a pretty good sized vessel, and it does supply a good area of heart muscle out here. And if you look at this, you see this branch right here has some disease right there, and we would bypass out here as well. So we would bypass the main artery, the diagonal, the one on the circumflex, and the right coronary artery. So we would plan for 4 bypasses.
Yeah.
More is not bad, it's just a matter of more blood flow. You know, it's like building more detours, you know. Nobody will be unhappy if you build more detours,
Right.
Cars will be moving, right? And same with blood flow, you'll have more blood flow going down the heart.
Right.
Interestingly, to do each bypass is less than the time we've spent talking about it. Okay.
Oh my
Each one
gosh.
is about 5 to 7 minutes, but the entire operation is about 3 or 4 hours, because the first hour is opening the chest, taking the blood vessels from the chest, and the assistant taking vein from the leg. So that's about 1 hour, then about an hour to do all the bypasses and everything, and then an hour to hour and a half to close up and get you over to the ICU and stuff.
So Brianna mentioned the possibility of if you find a bad valve and
Yes.
there was a choice between the porcelain or the,
Yep, so we're getting to that. So the first thing we talked about is the coronary disease. That is the indication for surgery. So the way I think about it is, was there an indication to do heart surgery, right? And the indication to do heart surgery for you was the heart catheterization and the coronary disease. Then we do testing to look and see what is the risk, and that includes an echocardiogram and ultrasound of the heart. So we're gonna take a look at that, and then we're gonna talk about the options of what we do with that. These are some cool images, I'm just putting them up because they're so cool. But what are we gonna do with it? We're gonna do nothing with it, but it just shows some detailed measurements of looking at the heart function and in different areas of the heart. But are we gonna use that clinically for you? No, because that's just overall globally, you had normal heart function. And that's shown here, the echo ejection fraction, 50 to 70% is normal, and yours is 67%, so it's squarely normal heart function. It's normal because you have blockages, but you have good blood flow getting past it. If you had had a major heart attack on the left side of the heart, it would lower the left heart function. And the right heart function can be affected by the heart attack you had on the right side of the heart. And fortunately, they said your right heart function was normal. That's on the right ventricle. That is the part that was affected by the heart attack you had, for which they opened up emergently.
okay, so,
That fortunately was normal.
good.
Okay, the right heart as well. So that's good that you have normal heart function. It's also good sometimes, like right after a heart attack and they open the blood flow, it's good to let some time elapse to let the heart muscle kind of recover from all that. So that's also good. Okay, so
So glad I got to the hospital right away.
yeah. The time to getting that opened is what determines how much of the muscle took a hit and is not alive anymore.
Yeah.
Wow.
Okay, so this brings us now to the echocardiogram. So we looked at the heart function, it's normal. The ultrasound of the heart also can look at the heart valves. There are 4 valves in the heart. They're like doors. They propel blood in one direction and prevent blood from going backward. This is not a great view, but this is the best that we got with the ultrasound of your heart. This is a cross-sectional view of one of the 4 valves in your heart. It looks like you have something called a bicuspid aortic valve. Normal aortic valves have 3 leaflets that open and close to, keep blood going in one direction. 1 to 2% of the population has a bicuspid aortic valve, meaning they have 2 leaflets instead of 3. This is a congenital condition. It would be something you're born with. And in some cases, babies coming out of the womb are so short of breath that they need to have an emergency surgery. Sometimes patients with bicuspid aortic valve, they are symptomatic in their teens and 20s and they get surgery then. Do you remember as a kid having trouble keeping up with your peers, like when they were running and stuff?
Absolutely.
You do?
To
Okay.
this day.
It's all right.
I
Interesting.
want to run.
So yeah.
I have the urge, but I can't do it.
Okay, so it's fascinating because I have had the same explanation that I've given to people in their 70s and 80s, and they're telling me, you're telling me about something I was born with and I've been on the planet for 8 decades.
I could have been an Olympian.
I'll say, yes, sir, you've been on the planet 3 decades longer than me, and I'm informing you of a congenital condition, because you have to think about how good was imaging in the 1950s or 60s.
Yes.
It wasn't that great. And even this is 2025, this is an ultrasound on the chest. This is not great image quality, but
Yeah.
it's the best we can get.
Yes.
Now, we can do better with the image quality if we do another test, okay? But based on the test we have, this shows what appears to be a bicuspid aortic valve. And then what they do, so people can have a bileaflet aortic valve, but they may be having no symptoms of shortness of breath, and they may have no exercise intolerance. So, before we knew all this, would you say, or are you short of breath when you go up hills or walk long distances? And if so, how long would you say that's been going on?
The past decade, it's gotten worse, and I
Okay.
would contribute it to age, and then I had weight gain.
Okay.
Now I'm more active. I'm
Okay.
losing weight, and
Okay.
it's becoming better.
Okay.
But I was
Uh-huh.
getting sick ever since last Christmas.
Uh-huh.
Eventually got pneumonia, so it's been a decline.
Okay.
And I just started feeling better when this hit me. So
I see, yeah.
it's a shortness of breath, and I also attributed some of it because I smoke.
Okay, gotcha.
And I had my last cigarette last Sunday night.
That's right.
Okay, that's excellent. I'll tell you a crazy story. I asked a woman who I did bypass surgery, I said, when was your last cigarette? She said, you're not going to believe this. I was having chest pain. I knew I was having a heart attack. I was driving myself to the hospital. I was so stressed, I started smoking a cigarette.
Yeah.
Then I was having so much pain, I couldn't finish it, and I threw it out the window.
Yes.
But she stopped, after the heart surgery, that was her last cigarette. She stopped. She said, I realized, so it's not about just stopping smoking. She told me clearly why she smoked. If you're gonna stop and you used it for stress relief, you gotta do something else, right?
Yeah.
So she realized I gotta do something else. Other people smoke because they like to have something in their hand, they're used to it. I say get a cinnamon stick because those things have the length and kind of thickness of it, and you can kind of chew on that. Cinnamon also cuts the craving for nicotine, so it's kind of a double plan.
Good.
So you got to kind of figure out why you do it, and then you decide, are you going to keep doing it or you're going to stop?
What's
And
the
so
replacement?
She stopped, and it was pretty amazing. If you had that powerful an addiction, you stopped on a dime. Can be done. You just got to choose what are you going to do.
Yeah.
So bringing us then to the valve. So we know you have a bicuspid. It looks like bicuspid aortic valve. The American College of Cardiology and the American Heart Association uses 3 criteria to tell, is the valve disease mild, moderate, or severe? If it's mild or moderate, if you didn't have another reason to have heart surgery, we would not recommend surgery, okay? So if it was mild or moderate and we didn't have another reason that we're doing heart surgery, we would just do medicines. What are the medicines? We would use medicines to lower your heart rate, because I don't know if you've noticed, if you're stressed or excited or your heart rate goes up, you're gonna feel worse if you
Yes.
have a valve disease like this. So we would use medicines to lower the heart rate, and we use water pills. Like, I don't know if your legs swell or you notice you have leg swelling.
No, but hand swelling.
Hand swelling. So we would use medicines to get fluid off, and that helps mitigate symptoms. If it's severe, then this alone can be a reason why we would recommend surgery or a procedure to fix it. These numbers, if the Vmax, the maximal speed of blood, is over 400 centimeters per second, that's severe. It doesn't meet criteria by that. If the mean pressure gradient across the valve is over 40, that's severe. So it doesn't meet criteria for severe. This is really moderate aortic stenosis, meaning based on the imaging we have, it's in the moderate range. The third criteria is the aortic valve area. If it's 1 to 1.5 square centimeters, that's considered moderate. So this is moderate aortic stenosis, meaning if we weren't doing heart surgery, we would just tell you, come back in a year, we'll get another echo, see if it's progressed, then we'll do surgery. And they do have, we just got in this trial. I had seen about this trial and I was trying to get us into it. There's a trial for a medicine that you can take to try to reduce the calcium buildup on the aortic valve. So for all these 30 years I've been a doctor, we've had no medicines to treat this problem. It's only been wait until they need surgery or something through the blood vessels. Now there's a medication trial for it, and we just got the trial. Like, we haven't started enrolling patients, but we had a research meeting this Monday and we talked about it, and I asked them to please print a sheet that we could give to people who we might be a candidate. So all that to say is we are doing heart surgery on you.
Yes.
Right? This can be either left alone or fixed at the same time. It meets criteria as a concomitant procedure, meaning if you have moderate, it is in the guidelines to do it at the same time to avoid having something later, right? So you could do that, or we just do the bypass and wait until you're recovered from the bypass and see about the candidacy for entering a trial for trying to do something to mitigate progression.
It's a tough decision.
Yeah, I think it's easier if you say this has been going on, for a long time, right?
Just fix it.
Yeah, and fix it at the same time. If some reasons why we wouldn't are your risk is so high that we don't want to add this to the risk. If your risk is not high, I think it makes sense to fix it at the same time. Now, what are the pros and cons of fixing at the same time? At the age of 60, there are two fundamental valve choices that we can do: a mechanical valve or a tissue valve made out of animal parts. The mechanical valve is the most durable treatment for sure.
That's the one I want.
Okay, that's the most durable, but you have to take a daily pill, a blood thinner, for the rest of your life.
Yeah.
And about 5 to 10 years ago, we were not really doing mechanical valves in people who are 60 years old. The data now shows that mechanical valves have better survival in a 60-year-old than tissue valves. And that's surprising, but it's because when you put a tissue valve in a 60-year-old, it is not likely to outlive you. Then you come back for another procedure, which mostly we're doing through the blood vessels. But it turns out that when you put a tissue valve and you later put another tissue valve in, the survival does not seem to be as good as patients getting a mechanical valve up front. Now, you do have to be on, because of your stent, you have to be on aspirin and Plavix for 1 year. Okay? Typically, aspirin and Plavix because you had a heart attack and you got a stent and bypass after. Now, because I'm bypassing the right coronary artery, and if you choose a mechanical valve, we should certainly try to limit the need for the Brilinta to like 1 month and then stop it, because if we don't, you would be on aspirin, Brilinta, and it's not advisable then to be on Coumadin for a mechanical valve. In fact, that situation alone is what has caused us to pivot and say put a tissue valve in to avoid being on 3 blood thinners. Okay,
that's a lot.
So this, if you were to choose a mechanical valve, I would talk to Dr. Tanevin and Jefferson and have them look again at the pictures and tell them, look, if I bypass the right coronary artery, are you okay with me stopping the Brilinta in 1 month? Or, and actually personally, I would say I would switch to Plavix, which is a weaker agent than Brilinta, because I think the risk of being on aspirin, Brilinta, and Coumadin, we don't do that.
Yeah.
Okay, it's just that is too much risk.
Yes.
Okay, that's too much bleeding risk.
So stop the.
Yeah, you don't stop anything now, but I'm saying to you, if you choose a mechanical valve, I would ask the cardiologist to look again at the stent result and everything, and I would say to them, is it okay if I just have her on Plavix, either aspirin, Plavix, and Coumadin, but stop the Plavix a month later? Or they may even say to me, don't put a mechanical valve.
Yeah.
Okay? They may also come back and say, she must be on aspirin and Brilinta for 1 year. Do not do a mechanical valve.
Okay.
So I will have to ask their opinion if we're even contemplating mechanical valve.
Okay.
If we're not contemplating mechanical valve, then I would just put a biovalve in and you would be on aspirin and Plavix or aspirin and Brilinta for 1 year.
And again, this is depending on her risk.
Yeah, I would say you could look at the risk to see, does it make sense to add it? I think your risk is going to be low based on your medical
So is
history.
that something that I would have to choose, or can I enable for you to, because honestly trust your decision over mine.
Oh, for valve choice?
Yeah.
Well, valve choice, you're the one living with it, so I want you to be comfortable. So to understand the implications, one, we talked about the bleeding.
Right.
The other is you hear a ticking sound in your chest.
Right.
Okay, so you have to be okay with that if you're getting a mechanical valve.
Right.
The second is that mechanical valves thin your blood and they interfere, the blood thinner can interfere with other medicines. So you have to get your blood level checked usually a few times a week in the beginning and later to like once a week or so. There are home kits that you can check it at home, but it is a lifestyle imposition. You have to change your lifestyle to accommodate to be checking your blood thinning to make sure. The third is that the blood thinner works through vitamin K dependent clotting factors, and the foods rich in vitamin K can make your blood thicker. So it's not that you cannot eat foods rich in vitamin K like green leafy vegetables, but your diet has to be fairly consistent week to week so that you don't have swings in your blood thinning. That's what I mean about it's a lifestyle imposition. So if you take a mechanical valve, you're sort of taking all of this package with it. If any of those things is not palatable to you, like ticking sound in your chest, going to the lab to get blood levels checked, being careful of new medicines being prescribed to you to make sure they don't interact with your blood thinner, and the dietary implications, then take a tissue valve. Because a tissue valve means you have to do nothing special, just do what you're normally doing. Don't have to go to the lab, don't hear a ticking sound, don't have to worry about your diet, right? So that's why mostly in people in their 60s we are putting in tissue valves, because as you get older you may have other procedures or things you need, and then being on a blood thinner impacts that.
I misunderstood Brianna then, because I was getting the impression that for the long term, because I was 60, whereas the tissue wouldn't last as long.
That's correct. That is correct. Yeah. The single biggest risk factor in the durability of a valve is the age, in a tissue valve, is the age of the patient when you put the valve in.
Okay.
Yeah. So, and these are all population statistical data, right? So I had a woman who was 30, and this, when I was first recruited here 11 years ago, she needed a mitral valve replacement. Mitral valves wear out faster than aortic valves. And she said to me, under no circumstances am I getting a mechanical valve. And she's 30 years old. I said, if I put a tissue valve in the mitral position in a 30-year-old, you're likely to get 5 years out of it, okay? Because they wear out very quickly in the mitral. It is 11 years later and it still has not worn out.
The tissue?
Yeah,
Wow.
the tissue, and she was 30.
Wow.
So population statistical data is population statistical. I've had other people, and one of my partners put in the latest generation tissue valve that we implant a lot of. I've implanted a lot of it, and he had it fail at 2 years after, on a patient who I think was in their 60s. We were surprised that it failed so quickly. So we have learned some things over the years on tissue valves. Is nowadays we check echocardiograms at 1 month and yearly after. If we see the leaflets starting to thicken, we put them on blood thinners to try to reverse that process. So there are things even on tissue valves where sometimes, and then there's a tick-borne disease that can affect the tissue valves that can lead to
What, like
premature
Lyme
valve
disease?
failure. It's not Lyme disease, it's called alpha-gal.
Okay.
Okay. So there are things that we keep learning about why tissue valves can degenerate faster. In that woman, I put the largest tissue mitral valve you could put in because the opening was very large. If the opening is small, we have learned if it's very small that it's better to enlarge it and put a larger tissue valve to have, longer durability on that. You know what I mean?
Because we're doing tissue.
Yeah. So
We'll
tissue
consider.
will be simpler for your life now and for potential procedures in the future. And, doing that with bypass surgery is more favorable to be able to fix a degenerated tissue valve through the blood vessels, you know what I mean, later.
Wait, can I interrupt?
Oh,
Does it
yes, sir.
simplify what the other doctors are working with as well, if it's tissue?
If it's a tissue valve,
Yes.
does it simplify what, I'm sorry, what were you asking?
Did it kind of simplify their approach to various things that they might face? So
Not
in
that
the future-
they would face, more that you would face.
Okay.
It simplifies that if you needed belly surgery or some other operation,
Yeah.
then you don't have to stop a blood thinner and worry about bleeding in the surgical site of whatever they do when we restart the blood thinner. So it's really a matter of simplifying your life is what it would do now. But like I said, mechanical valve, the durability data, and the modern mechanical valves that we use, they don't require as aggressive blood thinning as you used to in the past. The first 3 months, it's the same aggressive blood thinning, but after that, it's a mildly thinned blood that is acceptable because they found metals that are more resistant to clot.
Okay.
Okay. So I think you could go either way. I think even while we're thinking about it, I'll just ask your cardiologist what they think if we were to go mechanical valve. I'll ask them for their opinion. Separately, while we're sitting here and not doing the surgery, one other thought I had is to investigate the aortic valve further. Like I said, this image quality is grainy at best. One of the things that we can do is do a TEE where we put a probe down the throat to look at the aortic valve more closely. And a totally different thing that we can do is something called a TAVR CTA scan, CAT scan with X-ray contrast of your chest and belly. What that does is give us extremely detailed size information of the whole aorta, and that's what we do when we're fixing it through the blood vessels. If we do that, we will have a tremendous amount of information about making any valve decisions, like any at all, about tissue, mechanical, what are our possibilities in the future? It'll answer all of those questions,
Okay. Okay.
So we could certainly do that, and I thought I wouldn't do that today because you just had, X-ray contrast yesterday, you had X-ray contrast a few days ago. I would let that contrast wash out before we even talk about that, but when I saw the pictures, I thought that could be considered just to get more information, because it also helps weigh in on valve choice, frankly, because if it's a super large opening of your aortic valve, you feel very comfortable about a tissue valve because one, that's a bigger opening to start with. It has good strategies for through the blood vessels, that makes you feel better about getting tissue.
Yes.
If it's very small, makes you feel better about doing mechanical, or if you're gonna do tissue, then you gotta enlarge the aorta, but then, it's only more operating, so then it's like, is this the best strategy? So it at least will give us information.
Okay.
Awesome.
Okay.
Excellent.
So,
Thank you so much.
all right, sure thing, yeah.
I was certainly on a learning curve here today.
Yeah, for sure.
But thank you for explaining it like I'm a 5-year-old.
Honestly.
Well, I would be explaining it the same way even to some of the assistants, right? I mean, so like this is very nuanced and detailed,
Yeah.
So.
Right.
I had a quick question,
Sure.
actually. Just considering the trial, I know that it's a trial,
Yeah.
but if she were to go tissue valve
Yeah.
and later on would need another, would you expect things like that to be maybe another thing she could add? Would that be like an
No,
add?
if we replace the valve, that trial doesn't apply. The
Okay.
trial is only for people that have not had valve surgery.
Okay.
If we put a valve in there now, a tissue valve, and down the road that fails, putting another valve in through the blood vessels into that's already standard practice. We already
Great.
do that now.
Okay.
Yeah, we do
Great.
that now.
Okay.
Yeah.
Awesome.
Alrighty.
Thank you so much.
Sure,
It's so nice